Thank you so much, and thank you to the organizers for inviting me. These are my disclosures. The behavioral pain medicine clinical trials that I lead are funded by PCORI and also the NIH. These are my consulting disclosures. I'd like to just bring awareness to the continual need for us to de-emphasize the term alternative for non-pharmacological treatments and to continue to emphasize that we are simply treating pain. Words matter, and the language that we use has the capacity to either encourage engagement in these treatments or discourage it. I really feel that there needs to be a continual emphasis on appreciating the subgroups among our patients. So many of our patients are living with highly complex medical conditions. And for some patients who haven't tried any treatments, non-pharmacological treatment strategies are often the frontline treatment for them. But then other patients have tried everything, and they've really been down many different roads of non-pharmacological treatment strategies. And so for them, new non-pharmacological treatments may be a welcome addition to their pain care plan, but opioids may also be an important role. So I would just like us to recognize that what we really need are flexible policies that allow us to treat the person who has pain and not to focus on a reductive dose. We're not treating pill doses, we're treating people. So one treatment isn't better than the other or more virtuous. We simply need to deliver the right treatment to the right person and to ensure that we have a comprehensive evidence-based approach that really equips people with the ability to self-manage their pain as best as possible without demonizing the need to receive medical treatment, including opioids when those might be appropriate. In terms of other barriers, we definitely need better data on pain. We've heard a lot about that. We need better phenotyping. We need to understand the treatment effects. And here's what I want to underscore: the need to appreciate patient preferences and expectations. Because you can send a patient to see me for CBT, and if they don't want CBT, they're highly unlikely to benefit from it. So appreciating what it is that they want and need, and that's again where our pitch and our language can facilitate engagement. We definitely need improved education with clinicians and patients, and where I'm going to focus my time is on emphasizing scalable opportunities to really develop and apply scalable methods for both education, treatment, and also how we can leverage technology so that we can really apply some solutions that could have broad impacts, not just in the long term, but also in the short term. So in terms of education, sorry, let me find my sheet. In terms of education, we need to dedicate funding to upscale matriculation and professional training to meet the patient demand. And so in order to do this, we want to apply some scalable solutions. This could involve online cross-institutional collaborations, including the NIH, national pain societies, and even professional organizations, such as the American Psychological Association, for instance. And so we can develop community-based professional pain education that could be incentivized with reimbursement models. And then lastly, what I'd like to talk about is the imperative to continue to invest in the implementation of learning healthcare systems. I know there's a couple NIH calls out for proposals on this topic. At Stanford, we have the Stanford Collaborative Health Outcomes Information Registry. This is CHOIR. This is one example of a learning health system that we apply to phenotype patients and to deliver patient-centered care. We can phenotype patients at point of care and also longitudinally. This offers a platform for pragmatic research that we desperately need and for the deployment of scalable digital behavioral pain medicine treatments so that we can deploy low and no cost treatments, on-demand interventions, determine then who engages with the treatment, who responds to the treatment, and then allocate our precious resources to the patients for whom this is an insufficient level of care. For instance, at Stanford, my team is deploying a perioperative digital behavioral pain medicine treatment called My Surgical Success, free of charge to patients and to the hospital to help patients learn how to self-manage pain after surgery. We do need basic education for clinicians, but all clinicians are not going to become pain experts. And we can leverage technology to apply plug-and-play treatments and then close the gap that we have heard is 17 years between research and the transformation of clinical care. Thank you.